my patient today is Lonnie Gross. She's a 66-year-old female. She comes to us with complaints of chest pain. She describes it as a squeezing chest pain that radiates down her left arm and with intermittent episodes of shortness of breath. Now, she states that she has had these episodes before. None of them have lasted this long. This one has lasted about 2 weeks, and she states that if she rests, it does ease up. So, looks like her past medical history is hypertension and hyperlipidemia. She takes rosuvastatin for hyperlipidemia at bedtime for unknown dosage. She does not take anything for hypertension. She does lifestyle changes, diet and exercise at home to try to control her hypertension. She has no known allergies, and her only medical history is hypertension, hyperlipidemia. She has had an appendectomy years ago. She does have a significant family history that includes her mother passing from a myocardial infarction at 65, and her dad, who is living, I believe, died of Alzheimer's, but he had hypertension while he was living. The patient is a high school graduate. She works in an office 5 days a week. She lives by herself, and she feels safe at home, no thoughts of hurting herself or anyone else. She denies smoking, any use of illegal drugs, but she does state she drinks 1 to 2 glasses of wine a night while she is watching TV. As far as review of systems, patient denies any weight change, fatigue, fever, chills, night sweats, or energy level changes. She denies any wounds that aren't healing, no bruising or bleeding that she's noticed. She does endorse the squeezing chest pain, but denies palpitations and denies swelling in her extremities. She does have some shortness of breath, but denies cough, wheezing. She wears corrective lenses, but she denies any recent vision changes, denies any ear pain or discharge. She denies abdominal pain, nausea, vomiting, and diarrhea, and constipation. And she denies urinary symptoms that include urgency, frequency, burning, and no changes in her bowel or bladder habits. She has no sinus problems. She denies any problems with her breasts or lymph nodes, denies HIV, and she also denies syncope and weakness and blackout spells, as well as depression, anxiety. She does endorse some back pain at times, but doesn't complain of joint stiffness, swelling, anything like that. Upon physical exam, patient's height and weight, normal limits, and she's well appearing, has no acute distress. She's a little mildly uncomfortable but anxious. She's alert and oriented and answers questions appropriately. A little short to respond, though. In the office, her blood pressure was elevated, but the rest of her vitals were within normal limits. Skin is pale, warm, and dry, and intact. She has no rashes, no lesions, no open wounds. Head is normal cephalic, atraumatic without lesions. Hair's evenly distributed. Eyes found to have perla. No conjunctiva, sclera. Ears look good. No drainage or redness. No swelling at the neck. No nodules or patient's oral mucosa, pink and moist. No sores. No swelling, and teeth are in good shape. The patient's heart rate is regular. and unlabored, no extra sounds, murmurs, cap refills less than 3 seconds, and she has pulses +3 throughout, no edema. Patient's respirations are easy and regular, lungs are clear bilaterally. We did not assess her abdomen or breasts or urinary system. Patient had no difficulty moving in the room. Neurology exam was clear, speech was clear, good tone. She sat up straight, she had stable balance, and her gait was normal. She was alert and oriented, she maintained eye contact, and she spoke clearly with a normal rate and cadence. We ordered a CBC, troponin, D-dimer, chest x-ray, and EKG. All came back within normal limits. Although the patient has a high suspicion for CAD with stable angina, we do need to rule out heart failure and myocardial infarction, as well as a PE due to intermittent chest pain with the shortness of breath. The patient's family history does point towards CID and MI, and she does have a current diagnosis of hypertension and hyperlipidemia. The patient admits that she's not seen a PCP for almost 5 years, and that makes me wonder if she's compliant with her hyperlipidemia medication. She also has the history of hypertension, which she tries to control with her daily activities and diet, but if she doesn't follow up with primary care, it makes me wonder if how well she's doing that at home. The patient's BP was elevated in our office, and because of the extended period of time of the chest pain, I think we should initiate medication for the hypertension. I'd like to start the patient on a baby aspirin daily, also a beta blocker for the hypertension. The beta blocker I'd like to start would probably be metoprolol 25 milligrams PO daily for the angina, and also to reduce cardiac events. I would also like to prescribe sublingual nitro 2.5 milligrams times 3 doses at a time every 5 minutes to help relieve the angina. I would like her to follow up with cardiology within the next few weeks, and I would like to provide education regarding medication compliance, as well as follow up with PCP and preventative care.